Guess who's back? Well, today we're going to be working on integrated pulmonology. And just like everything else, we're going to bring in the relevant topics from basic sciences so that the information that is being delivered will be the most relevant clinically. Immediately, here we'll begin with the development and things that may go awry with development, which would then give you certain presentations in your patient. For example, I want you to start thinking about the development embryologically of the lungs itself. And I need you to understand that the lungs are developing from well, you tell me. Is it the foregut? Is it the midgut? Or is it the hindgut? It's the foregut. The foregut is where the lungs begin. That's important for you to understand because that foregut also gives rise to something that we know and love, which is the esophagus, because we love to eat, don't we? And I love my cheesecake. What's my point? My point being is because the development of the lungs begin with the foregut, initially, the esophagus and the trachea may not have a separation. This story kind of reminds you of the separation that took place in the cardiovascular system with the truncus arteriosus, doesn't it? However, here, remember, the septum is going to separate the trachea anteriorly from the esophagus posteriorly, and I think you know what I'm getting at. What if you had a child in which, upon delivery, so viability of birth is definitely intact. Upon first feeding, there's going to be regurgitation, blah, just like that. Not projectile vomiting, not going to be bilious vomiting, but then simple regurgitation that's taking place from the child. Right off the bat, that should give you a differential of maybe perhaps that the esophagus did not properly develop. Well, Dr. Raj, what does that have to do with pulmonology? It has everything to do with pulmonology because both of these structures are developing from the foregut. What two structures? The esophagus posteriorly, anteriorly, the trachea. Well, what then happened? Well, what happened with the regurgitation, with that first feeding, was the fact that the esophagus proximately was undergoing atresia. What's atresia mean to you in medicine? It means lack of development, Lack of development. You've heard of duodenal atresia in Down syndrome. You've heard of tricuspid atresia in congenital cyanotic heart disease. Here we have esophageal atresia, but what part commonly of the esophagus would undergo atresia? 95% of the time, it would be the proximal portion that the esophagus would undergo atresia, which makes perfect sense because here, upon first feeding, what happened? The child was regurgitating. Well, how would you perhaps go diagnose this? Well, you want to feed the child, and so therefore, uncomfortably, you're going to place an NG tube, a nasogastric tube, and when you do, guess what you find on X-ray? Imagine now that the tube is then going down the child's esophagus, and when it does, what's it going to do? Oh, it's going to loop. Why is it going to loop? It's going to loop because the proximal portion of esophagus has undergone atresia, lack of development. Prior to birth, what did you find? Take a look at this ultrasound of the womb of the mama. And the ultrasound is showing you increased amounts of amniotic fluid, increased. So would you then refer to as being oligo or polyhydramnios? Polyhydramnios. Why? Well, not only was the regurgitation taking place that you witnessed personally, perhaps as a parent with delivery, but as a doctor or as a technician, you noticed polyhydramnios because the child was quote-unquote vomiting or regurgitating amniotic fluid and building up amniotic fluid, polyhydramnios, in the placenta or amniotic cavity, correct? Viable with birth, thank goodness. What else might you find with this particular tracheoesophageal fistula? Up until now, we've only been focused on esophagus, but yet we're doing pulmonology. Yes, we are. Let's move on to the issues that you will find with the respiratory system in tracheoesophageal fistula. So far, I've given you esophageal atresia of the proximal portion. I've given you clinical findings that you can expect. What about the fistula? In the distal portion, you would then find a fistula between the trachea and the esophagus. Fantastic. Well, what does that mean to you clinically? Let me ask you a question. If there is a fistula between the trachea and the esophagus, is it possible that you may then find accumulation of gas in the stomach? Is that a possibility? Sure it is. So you're going to look for a gas bubble. Now, is that going to be pathognomonic and specific for a pattern of tracheoesophageal fistula? No. So there'll be other patterns, but we're not going to go through every single one. We're going to go through the patterns that you will quickly then identify on your boards and in the wards, right? So far, we got a gas bubble, tracheoesophageal fistula. Is it possible that you may then get gastric content into the respiratory system, and if you do, infection may then set in? Oh, that sounds awfully familiar. Yes, it does. Because the opposite exchange of gastric content into the respiratory system is then going to give you fever in that child, notably secondary to aspiration pneumonia. So if you have air that's going into the GI system, you're going to find gas bubble in the stomach. If you have gastric content that comes into the respiratory system, that child's going to be suffering from aspiration pneumonia. Fascinating, isn't it? This pattern is what we call your tracheoesophageal fistula and distal portion with proximal esophageal atresia. This is 85% of your patterns due to the fact that the foregut, the mesodermal septum or the tracheoesophageal septum, did not properly divide the trachea anteriorly from the esophagus. So, Dr. Raj, are there other patterns that I must know? Yes, there are. Take a look at this stomach. Oh, we got another gas bubble. Yes. Earlier, I just mentioned that finding a gas bubble in your stomach is not specific for one pattern. And in this pattern, you might find gas bubble. In this pattern, however, what you will not find is the looping of the NG tube. You'll not find regurgitation upon first feeding. You're not going to find polyhydramnios because guess what's missing in this type of tracheoesophageal fistula? The esophageal atresia. So if you don't have the esophageal atresia, why would you have regurgitation? And why would you have polyhydramnios? And why would you have looping? You don't. This pattern is then referred to as being your H pattern. And this will be approximately 10 to 15%. So right there, these two patterns gives you almost 100% of the patterns that you can expect in tracheoesophageal fistula. I want you to take a look at this picture. What do you notice? There's no gas bubble in the stomach. There's no gastric gas bubble. So now you've ruled out the H pattern, and you've ruled out the most common pattern of tracheoesophageal fistula. But why did you not have a gas bubble in the stomach? That's because there was no fistula between the trachea and the esophagus. This is what you refer to as being a pure esophageal atresia. EA. It's a pure esophageal atresia without having a fistula. Thus, you don't have a gas bubble in the stomach. All due to issues in the foregut. Hopefully, we've created a bigger picture for you in terms of embryologic pathology of the respiratory system, but obviously discussion also here took place of the GI. We had to. Let's continue discussion a little bit more, shall we? Through the embryologic period of the lung. What's that first stage of lung development called? Oh, how convenient. It's called the embryologic stage. It's called the embryologic stage. The development of the lungs, like that of the cardio, begins at 4 weeks. But the biggest difference is the heart actually starts beating and is autonomous at 4 weeks. The lungs, however, are not. In fact, the lungs really do not function autonomously, or should I say, participate in gas exchange until approximately 20 weeks into development of the lungs. And that stage is referred to as being your canalicular stage. Now, there are other stages embryologically that you'll have to know. You do that on your own. But our main focus here in integrated pulmonology will be the embryologic period. And the reason for that is because we just discussed our tracheoesophageal fistula. During the embryologic period, the things that are developing in the foregut for the lungs include the lung bud itself. So you got this little foregut mesodermal diverticulum that gives rise to these little baby embryologic lung buds. Oh, so cute. What else does it give rise to? It gives rise to bronchial buds in the embryologic period of approximately 4 to 7 weeks. That's amazing that all this is occurring. Also, it may give rise to the trachea, the mainstem bronchi, maybe the lobar, secondary, and the tertiary segmental parts of the bronchi. Embryologic period, clinical significance, tracheoesophageal fistula. You got buds that are being developed. The next stage quickly is called the pseudoglandular, completely incompatible with life. And then we get into canalicular. How do we know if the lungs are properly maturing? Seriously, in this embryo, how do we know that the lungs are properly maturing? How do we know that the child is properly breathing? How do we know that the ductus arteriosus is going to close? We're going to follow what substance biochemically? Oh, it's called dipalmitophosphatidylcholine, DPPC, the most important constituent of, tell me, surfactant. Good. Allow the name to speak to you. Surfactant. In you and I, in a child especially, in the canalicular stage, beyond 20 weeks, is going to reduce the surface tension that the alveoli is going to start feeling for collapsing. The surfactant is going to reduce the surface tension. Surfactant, dipalmitophosphatidylcholine. All must be memorized. All must be understood. What stage of lung development are we in? The canalicular stage. Where am I in terms of weeks of gestation? 20 weeks and beyond. Is it possible that the lungs at this juncture could start participating in gas exchange? Yes, it can. Amazing. And I want to make sure that the child doesn't go into NRDS, neonatal respiratory distress syndrome. What are you going to follow? Surfactant. What is that called clinically? Take a look at this ratio. L over S. You would think that the S conveniently could stand for surfactant, but does it clinically? No. It's sphingomyelin. Sphingomyelin doesn't represent the concentration of surfactant in the lung. It does not. But the lecithin does. It represents surfactant.